Welcome, everybody. Thank you so much for joining us today for our Data to Drive Decisions webinar. We're talking about alternative payment models today and shifting from fee-for-service in Colorado. We'll be touching on a couple of things. I'm your host today. I'm Carrie Frank. I'm the Vice President. I don't even know my own title today. Vice President of Marketing and Communication here at CIVHC. And our topic again is alternative payment models. We'll be discussing what we are doing at the civic side of things in terms of data collection and what we're seeing across total medical spending. And then we're going to dive into primary care in particular and talk about the Primary Care Reform Collaborative and the work that's being done there, recent legislation that has been passed to advance APMs, and then also an overview of Medicaid's role related to primary care APMs. We will have some time for questions and feedback from participants at the very end, but feel free. We're recording this session, and throughout the entire session, don't wait to chat the questions into the chat box. We'll take them at the end, but feel free as they come to you to put them in the chat box. I know it's hard to remember questions if you're trying to wait till the very end, so feel free to do that throughout. We have an amazing lineup of presenters today. We have Dr. David Keller. He's a pediatric doctor at the University of Colorado School of Medicine and Children's Hospital of Colorado. He's professor and vice chair. He happens to also be a member of the collaborative that we'll be talking about today, and an important member of the APCD Advisory Council that we have, and we're very grateful to have him. Maria de Jesus Diaz Perez, she's with CIVHC, and she's our Director of Research and Performance Measurement, and very involved in all of our APM work. She's our subject matter expert. Also have Tara Smith joining us from the Colorado Division of Insurance. She leads the primary care and affordability work, and she's the director there. Also have Representative Chris Kennedy from District 23. He's going to be talking about the new legislation that has passed. And then Trevor Abeyta with the Colorado Department of Healthcare Policy and Financing, our state's Medicaid department. He's the payment reform section manager. So we have a great set of presenters, and before I get to them, I just want to quickly talk about CIVHC's mission, just in case you're encountering CIVHC for the first time. Our mission is to empower individuals, communities, and organizations through collaborative support services and providing healthcare information to advance the triple aim. Everything we do is to make healthcare better, cheaper, and more coordinated and high quality. We're a nonprofit, independent, and objective organization. And we serve a wide variety of change agents, really anyone who touches healthcare, which is all of us, from consumers to clinicians, hospitals, employers, state agencies, and government, researchers, health plans, and nonprofits. So a lot of the work that we do is through the Colorado All-Payer Claims database. And today we're talking about APMs, which actually comes in as separate files. And Maria will talk to you more about that and how that data is collected. But within our monthly submissions, we have commercial payers, Medicaid, and Medicare. And it encompasses 870 million claims, and that's from 2013 to 2021. We have claims that go back to 2009, but most of those have been archived up until 2012. And it encompasses over 5 million lives, which represents nearly 70% of the insured if you're looking at just medical, but we also have dental and pharmacy as well. And it is all encompassing from 2013 to present. And really the advantage of an APCD is that we can track people over time. So if people are going from commercial insurance to Medicaid and off and back, we don't lose them. We can track them over time. So it's a very rich and deep data set. So we turn that into public information, which we'll talk about today. All the APM data that you're going to see today from CIVHC side is all online and available publicly, and we have a multitude of public reports that are available. And then we do also provide non-public data requests to researchers and state agencies and other folks who are doing specific projects that they are trying to advance the triple aim. So with that, I'm going to turn it over to Dr. Keller first, who's going to give you kind of more of a background on APMs if this is your first time even hearing that acronym. So Dr. Keller, thanks for being here. Take it away.
Thank you so much, and thanks for that kind introduction. I have been privileged over the last decade to really work on this issue a lot in a lot of different venues, Civic and the Primary Care Payment Reform Collaborative being two of my favorites. My title is Alternative Payment Models. We're paying for value, not just for volume. And I think that's the underlying opening premise here, is that a lot of the problems in our healthcare system are caused by the way we get paid. And I'm a pediatrician, so I'll tell you, I get paid by the visit. I get paid for every procedure I do. And so the more procedures I do, the more revenue I generate for the system. And that's generally true throughout all of our systems for the last 100 years. That providers, whether it's a hospital or a doctor, or an MRI center or anything else, they get paid. The more things they do, the more they get paid. And we call that paying for volume. Next slide, please. So our idea is that if we want to change the way we practice, because when you get paid for volume, what that incentivizes you to do is see more volume. So the complaints we get from patients are that we're trying to see too many patients and we're making our visits shorter so that we can see more volume and things like that. So if we change the way we get paid, then we will drive changes in practice. That's the big idea. And so the big idea is that we need to pay for value, not just for volume. And as was pointed out by a doc about 10 years ago, Paul Grundy, if you're going to regulate something complicated, you need a lot of dials. Right now, our only dial is volume. If we want more money, we want to increase the revenue, then we add more volume. If we have enough revenue, we decrease volume. And that's pretty much what we do. And so he has this little image of, a control panel that I like to use. But the way we think of value-based payments is these are the dials that we're going to use to try to change the way the healthcare system works. Next slide. So what do we mean by paying for value? And this has been the subject of a lot of thought over the last decade. And there's a group called the HCPLAN, which I am not going to tell you what it stands for because I get it wrong every time I say it. But it's a group of people who pay for healthcare, and a group of people, and along with folks who provide healthcare, who've gotten together and tried to define what the different categories of these different alternative models of payment could look like. And they've set it up into 4 big buckets, and each of those buckets has some small buckets within it. I'm just going to describe the 4 big buckets, and if you want to know more, I'm happy to. There's a link at the bottom where you can look it up. So category 1 is the way that we currently get paid, fee for service, no link to quality and value. Category 2 is when you are linking that payment to some measure of quality and value. And that's sort of the first level of alternative payment models. Then there's category 3, where you are building this new kind of architecture onto a fee-for-service system where you're still getting some of your money by getting paid fee-for-service, but you're also generating payments because you're able to manage either a condition or a population or something better than other folks do. And category 4 is what they call population-based payments. Let me go into each of those a little bit in the next few slides. Next slide, please. So here's the classic fee-for-service payment system. Physician performs a service, we code the service, we put that code onto a bill that gets sent to your insurance company. The patient pays a little bit, the insurance company pays more of that bill, and how much they pay is based on those codes. So as a provider, what do I need to do to be able to make that system work? I need to be able to code well, and I need to have adequate volume. And so if I see a problem with how I'm getting paid, what I do is I look at my coding, and that's happened a number of times. People spend a lot of time looking at that, trying to figure out, am I coding properly to get paid for what I'm actually doing? And or I try to find ways to add more volume to my business. And that's pretty much what you can do is as a business person within medicine to try and increase your revenue stream. Next. What do we mean by linking it to quality and value? So there, the provider performs a service, they code the service just like they did before, and all of those things happen, except when the payment comes, some part of that payment is based on how you performed based on some sort of quality or value metric. And that's where we get into this whole notion of measuring quality. Now, the picture next to it is a practice I worked with in Rhode Island that had moved to a value-based payment system, and they were touting themselves as being the medical home. They were going to take care of you in a way that's different than someone who's just trying to see you for an individual visit. And that's requires you as a practice to understand, what do we mean by measuring quality, and how do we improve the quality of care that we have? You have to have a system in place to be able to improve quality of care. And so that's the first category. And that actually works reasonably well. If you start telling people, if you start grading physicians on their quality, we're all A students, we all want to do well. And so we'll start doing things differently and better. Next category. So then we have this thing called the APMs, built on fee-for-service architecture. And I apologize that this is unclear, because this is the one that is hardest for me to understand. What they do here is all the same things that you do in the previous system, except at the end, the insurer, the payer, and the provider look at how much money they may have saved in the system, and they split it, and they share in what savings they've been able to generate by eliminating waste within the system. And that requires you to move on to something called managing population health. That's the new component that we want practices to add to be able to do that. And that means they need to be able to identify a population. They need to be able to look at the data on the health of that population. They may need to come up with some way to reach out to that population who's not necessarily showing up in their offices. They need to have collaborators in the community to help them do that. It's really a restructuring of how you do your practice, and it's the beginning of that. And it's a big deal. And I would say when Trevor Abeyta talks later, he's going to tell you what Medicaid is doing. And this is where Medicaid's system sort of fits right now, is into this sort of transitional stage where we're trying to figure out, how do we get some of the waste out of the system, and then what do we do with the benefit of that, of eliminating that waste. Next slide. The final category is what they call population-based payments. Now, this you've probably heard of. This is popularly called capitation, and involves getting paid, told that, assigned a population of people that you're covering and providing services to that population. And then you know how much money you have, and you get to manage that money, and you need to be able to determine that you have enough money to manage the population you're taking care of. The key in here, the key new skill in addition to managing population health, is that you need to know how to manage risk in this population. You're actually taking a lot of the risk. If you guess wrong and don't have enough money in the bank, you're the one who takes the loss. And so this is really the hardest of those categories, I think, to manage. Next slide, please. As always, the devil is in the details. And one of my colleagues on the Primary Care Payment Reform Collaborative, Stephanie Gold, put together a nice sort of critique of all of these different models. What are the problems in all of these things? And in this nice table she put together for us a couple of years ago for the Primary Care Payment Reform Collaborative. And as you can see, when we're in a traditional capitation model, you don't have much of an incentive to take on complicated patients, because those are the ones that are hard to predict how much money you're going to need. Also, for all of these, basing how much you're getting paid based on prior payments for primary care kind of locks us into a system where primary care didn't get very much money, and all of them have that problem. So none of these things are perfect, and you can find lots of critiques about whether these alternative payment models work or not in the literature. But I will tell you that the ones that have worked, I think, are the ones that focus primarily on the quality of their performance rather than on the financial management aspects of this over time. So hopefully these new systems will move us in that way. Now, I said I would give this talk if they let me make one more point, because I'm a pediatrician. A lot of the programs, and Trevor's laughing because he's heard me say this way, and Tara have heard me say this way too many times. For a lot of these programs, as I said, eventually move to the point where the key to managing them is the elimination of waste. And the good news about the care of children is that it's relatively inexpensive, and that we don't have as much waste to get rid of as our colleagues in the adult world do. And so there are problems with trying to design these kind of payments in the pediatric population. We have a lot of the stuff in the adult population is based on the management of chronic disease. The good news is that most children don't have chronic disease, as opposed to most adults like me who have 3 chronic diseases. So, it becomes harder to design those systems. Kids are incredibly susceptible to social conditions. And so in addition to being able to adjust for the medical risks, which we do in the adult population, we need to know how to adjust for social risks for kids. And that's much harder. And there's probably less waste. So there's less waste that you can convert into payment, which is kind of the premise of a lot of the systems we heard before. So I'll end with that thought. And then now that I've been talking health economics at you for 10 minutes, I'm going to let you stare at a beautiful sunset from Mount Evans before we move on to the next speaker. Thanks very much.
Thank you so much, Dr. Keller. Yes, if at any point in time our presentations get overwhelming, just think of this vision and take some deep breaths. We'll get through it together. All right, Maria, I'm going to hand it over to you.
Thank you, Carrie, and good afternoon, everyone. Thank you for joining us today. I'm going to follow on Dr. Keller's presentation, who gave us a really good baseline on how to understand the importance of alternative payment models. And I'm going to tell you a little bit of the mechanics and how the Center for Improving Value using the Colorado All Payers Claims Database have been working to produce a report on primary care spending and the percentage of spending that is done in alternative payment models, as Dr. Keller described. And this started in 2019, as established by the House Bill 1233, and you will learn much more about it later. CIVHC started collecting APM files, which are in addition of claims files, to produce a report that will inform the spending that is done in Colorado in primary care out of total medical spending, and what share of that spending is due to alternative payment models, which is the intention of this bill, not only to increase utilization of primary care, but also to do this through the investment on alternative payment models. Could you tell me, pass this, go to the next slide, Carrie, please. And I'm going to tell you a little bit of the history of the alternative payment models. As I said, the collection of APM data started in 2019. And at the beginning, Colorado adopted the model used by Oregon Health Authority to produce the first primary care spending report and first APM spending figures. But in 2020, with the establishment in the Division of Insurance of the Primary Care Payment Reform Collaborative, the collaborative implemented a specific definition of primary care for the state of Colorado, and they also implemented the HCP land categorization for APM collection that was described also by Dr. Keller. And that was important because then that meant that we worked together with the collaborative and the DOI to create an operationalization of the primary care definition using the claims, and also to request the submission of non-claims data. We also discovered as a result of the first report that we needed to make some technical modifications to the APM data collection, and that was mainly to use Colorado residents instead of the place of the legal contract of the health plans, and also to add the line of business detail. The way we collected data before, we couldn't provide that detail. But in 2020, which was the most recent data collection, many changes, very important changes were adopted, and the most important change was to identify in the files what payments are done prospectively, because that's important for practices and for primary care transformation particularly. But we also included a qualitative supplement to the APM files quantitative submission. What this qualitative supplement does is that health plans described all the contracts that go into the final APM numbers, and they describe each of the contracts along a series of characteristics. For example, they describe if the contract First, as they describe if the contract is classified as a 2A, 2B, 2C, where it's classified according to the HCP plan framework. And then they describe if it is population-based, if it is prospective, if it has upside risk or downside risk, all the characteristics that are included to classify alternative payment models within the HCP land framework. This is very important information because that allows us to check with health plans that the operationalization of the data they were submitting corresponded with the intention of the category in the HCP land framework. So that was very important and help us improve the data collection, the validation, and the engagement with carriers beyond only the data team of the health plans, but also the policy team of the data health plans. And that drive also the attestation. I don't want to miss to say one thing, that this work that I am talking about now is just me, but represents a very large team in CIVHC that goes from the data collection, quality team, and then the reporting team also. Could you go to the next one, Carrie, please? Just to tell you a little more about the process of data collection, CIVHC receives APM test files from each of the payers that submit APM information in July. And then CIVHC validates that data against the HCP line framework and the contract, talks with the carriers, has many conversations, and then we receive the fixed or a revised file later in the year in September. This file is again, it might need other adjustments. That is done, and then we receive a final attestation at the end of before the report is due in November. One thing that is important to mention is that not all health plans in Colorado pay through using alternative payment models. So the first step is that those payers who do not pay using non-fee-for-service ways, they request a waiver to submit data to the Colorado APCD. That waiver is granted, and then it is only 13 payers, for example, in 2021, who submit APM data to CIVHC for this report. Could you go to the next one, please, Kerry? Okay. What we have learned since we started collecting data, one of the first things, and of course, Tara and Dr. Keller are very familiar with this. One of the first decisions that had to be done about what constitutes total medical spending is that if we were going to include pharmacy, dental, or vision services, as it is right now, total medical spending does not include pharmacy, dental, or vision services, and not including these is pretty much the way other states have done it, but there is always like the question: is this the way we want to stay, or is there an opportunity to modify the denominator and include all the other expenses in healthcare? One thing that we have learned is the value of continuous engagement with health plans, and by continuous engagement, meaning not only with the data teams, but also with the policy team, making sure that bridge between the conceptual part of how the APMs are designed translates to the data that we are receiving for these reports. And also, of course, the implication of primary care definition. As you know, many other states have been adopting similar initiatives of increasing spending on primary care, and each state defines primary care different. And just to add to that, each payer, each health plan defines primary care providers different for the plan. So what Plan A in Colorado identifies as primary care provider might not coincide with Plan B identifies as primary care provider. Of course, we as the recipients of the data guide the submitters with a specific primary care definition, but we need to make sure that definition is followed, and that is, as you can imagine, is not straightforward, particularly in the non-fee-for-service plan part of the equation. The other thing that we have continue to work, and we still have to continue working on, is to make sure that the way Medicaid is paying for primary care and alternative payment models is represented the best way in the data. And as you know, the Colorado APCD receives payments from all the health plans, and Medicaid, as the state agency, pays directly to some provider, but also we received information from the health plans who are contracted to manage the accountable care collaboratives. So we need to make sure that all these pieces are represented properly, and we continue working very closely with Medicaid to achieve that. I think we made great progress from 2020 to 2019, but we know we have still more to do. And I would like to mention also another piece of challenge in the collection of APMs is how we are categorizing the HCP land. I think Dr. Keller said it well, the devil is always in the details, and many states have adopted the HCP land framework as the categorization, as the standard categorization for APMs, but we don't know to what extent we might be operationalizing those categories differently when we collect and report the data. So there is still more work to be done. And the other piece that is very important to mention is what is going to be the level of aggregation for the APM data collection. So far in Colorado, we are collecting data at the billing provider level. But as we progress and we adopt APMs, we would like to see if those APMs are making a difference in the population health, care, and access. And for that, we're going to need more information about who is being covered under these APMs and who's not. So we might need to add other layers of other data points to the data collection. Next one, please. And this is just a very, very broad overview of the alternative payment model spending in Colorado. I invite you to go and check the report that is available in the website. This is the percentage of alternative payment spending out of total medical spending from 2018 to 2020. In these graphics that are broken by Medicaid, Medicare Advantage, and commercial, what you can see is that we are also including integrated systems in the state of Colorado, and we are including all types of alternative payment models, not only value-based payments, as Dr. Keller made that difference. And this is any non-fee-for-service payment is included here, and we are also including the share of integrated systems who take care of a very large segment of the population in the state of Colorado. You can see that the spending seems to have decreased a little bit over 2018 and 2020. I have to say the 3 years we're collecting in one data submission in 2021. So they are all exactly comparable data with the same parameters and same data submission. Next one, please. I forgot one point from the other one. Could you go back, please, Carrie? So this is for each of the payer types, but if we overall across all the payers from 2018 to 2020, if we look at the percentage of APM spending, we saw that we had 38% in 2018, and it came down to 33% in 2020, if we include integrated systems and APMs. And now the next one. And in this one, it is exactly the same, but in this case, we are not included the integrated systems, and we are only including the value-based APMs. The value-based, those who have quality, those who have a measure of quality. So in a way, the first one would be the less strict measure of APM, and in this case, is the more strict measure of APM, or ideal measure of APM. And as you can see, also, there is a decrease, particularly among the commercial payers, not so much in the other payer types. And in this case, the APM percentage spending went from 27% to 21% in 2020, from 2018 to 2020. Next one, please. This is just another view for only commercial payers in 2020, and commercial payers overall spent only 11% of their total medical spending in alternative payment models or non-fee-for-service. Next one, please. And this is a little bit more detail on what type of alternative payment models they used. And this is also for all the payers in 2020. And you can see that still the most predominant type of payment is pay for performance, which is, as Dr. Keller explained, what we would like, ideally, we want to move to force instead of two, which is still like in transition to adopting full alternative payment models. But it is still pay for performance, the most predominant type of payment if we do not include the integrated care systems in Colorado. And just a last word, because I think this is this is just the affordability dashboard, which you can go and see. These were just a few data points that you can find in the dashboard. But I just wanted to mention that you see like the decrease of APM spending in 2020. But we know very well that 2020 was a year like no other. So we collected data from the health plans. We asked in which way COVID had affected their primary care spending and their APM spending. And even when qualitatively, most of the health payers said that primary care, of course, decreased for a time, but then came back. If you look at the data, you see that for most payer types, with exception of Medicaid, the primary care spending actually decreased in 2020. And in APMs is about the same. Payers said that they didn't perceive a big change, but the truth is that the APM spending decreased also for pretty much across the board, with exception probably of Medicaid also. And one thing that is that we know and is that we will need to do many other analysis to just make sure what is exactly different and what happened with the spending during 2020 to make sure that change, because they didn't change the APM spending, but something else changed because we are seeing the decrease overall in 2020. And that's all I have. I invite you just to see the report whenever you have a chance and come back with questions. Thank you.
Thank you so much, Maria. And we've heard from a few of you participating out there that the chat is disabled. So I sincere apologies. It looks like Zoom updated things, and there's a deep setting that we didn't know that we needed to turn on before. And so unfortunately, we're not going to be able to take questions via chat, but we would love to still hear questions from you. If you want to send questions to Sprigg, SPRIGG @civic.org, or you could also send to info@civic.org. That would work too, CIVHC.org. And we can field questions from there, and we can always answer questions after the fact too. So apologies for that little glitch. Always fun dealing with technology just when we think we have it nailed, right? So I'm going to go ahead and turn it over now to Tara Smith from the DOI. Thanks, Tara, for being here. I'll go to your first slide.
Great, thank you. It's always dangerous to invoke the specter of technology difficulties and then have me up next, because I can take any platform out there, I promise. I still have not learned how to survive well in a virtual world 2.5 years ago. So hopefully we will go smoothly here. Good afternoon. Yes, it is afternoon now, everyone. Again, my name is Tara Smith. Really excited to be part of this conversation today. I'm very honored to be part of this panel of great state leaders who I am lucky enough to call colleagues and collaborators and occasionally co-conspirators. And so really, really excited for today's conversation. I'm going to pivot a little bit with my remarks. I think and talk a little bit more specifically about APMs as a specific strategy in some of the state's efforts to increase investment in primary care. So we got a great overview of kind of the what and the why of APMs from Dr. Keller, right? Like what actually are these types of payment arrangements? What are those different buckets that are involved? And really, why are we interested in this type of payment at all in the first place, right? And it's really that capacity to drive value into the healthcare system, right? To sort of reorient the system away from a fee-for-service, increasing volume, and cost, to a system that's actually designed to look at quality and improve health outcomes while reducing healthcare costs. Maria then jumped in with a little bit of what I would call kind of the how, right? At a systems level, then how are we thinking about actually trying to operationalize and capture this data? Sorry, my cat just woke up. That's not someone dying in the background. That's just my very bottled cat who is going to meow for a little bit and then he will fall back asleep. But really kind of the how of an APM and how we're thinking about trying to capture that and quantify so we can start to measure and track that over time and really understand the impact that this different type of reimbursement arrangement is going to have on the outcomes we care about, on healthcare access, on healthcare quality, on affordability, on health equity, hopefully, and as well as costs. So I would say kind of myself and Representative Kennedy and Trevor are going to be more around the kind of who and where and when, kind of how is Colorado as a state using policy and some of the other levers that we have now to look at supporting and advancing the use of APM specifically in the context of primary care and really helping to strengthen and build out Colorado's primary care infrastructure. So Maria already kind of flagged this as a upcoming attraction in the presentation. This is House Bill 19-1233, which was passed by the state legislature in 2019. The title here actually is dead on in terms of what this bill did. It was concerning payment system reforms to reduce healthcare costs by increasing utilization of primary care. So the idea is that there has to be a strong primary care infrastructure in place for a state to really have a high functioning healthcare system, right? To have a healthcare system that is able to provide equitable access to high quality, whole person integrated care delivery in a way that reduces costs. You really need to have a strong primary care foundation. We know that historically the US has not done well in terms of the amount of total medical expenditures that are spent on primary care. You look at other countries, they're about 14 to 15%. In the US, we've been closer to 5 to 7. So knowing this is an area in Colorado and really nationally that we want to be increasing investment in. So the two new tools that this bill added in our toolkit, one was the creation of this primary care payment reform collaborative, which Dr. Keller has generously served as co-chair for the last 3 years. The other key piece of this bill, and the reason you have an insurance regulator in your midst this morning, is that it gave the Division of Insurance the authority to include affordability as part of the rate review process. So in addition to reviewing health insurance rates for things like, are they excessive, are they inadequate, are they unfairly discriminatory, we can now look at commercial carrier strategies for making insurance more affordable and doing that through strategies like investing in primary care. So with these two new tools in our belt, one other, if you want to go to the next slide. These two things are related to each other, right? One of the primary care collaborative's main goals is to be providing recommendations and advising the commissioner in the development of those affordability standards. So you can see kind of the list of tasks that this group is involved with. The composition, it is purposely a multi-stakeholder group. So we have both public and private payers around our table. That includes commercial insurance carriers. That includes our partners at HCPF and Medicaid, our federal partners from CMS. We also have healthcare providers, so family physicians, primary care docs, also pediatricians have been an important part of this group's work to date. We have consumer voices at the table, some of our consumer advocacy organizations, as well as our partners from CDPHE, some actuarial experts, as well as employers. So intentionally a multi-stakeholder group to be discussing ways and making recommendations for how we're strengthening primary care. You can see in the list of responsibilities, APMs are very much in a part of this group's consideration and strategy. looking at how they're currently being used in the market, identifying those barriers, and making recommendations on how to increase their adoption. If you want to go to the next slide. Maria did a beautiful job of touching on this already. The 1233 intentionally created a reporting mechanism, right? So the idea is not just, hey, let's spend more money on primary care and hope for the best, right? It's really, as we're increasing investment, wanting a way to understand and track the impact of that investment, again, on all of the outcomes that we care about. So Maria already went through this, right? It's an annual report that's submitted to the DOI for use by the collaborative that looks at that, it's that market-wide perspective, right? So it includes commercial as well as public payers. And it looks at spending. The one thing I would note is when you're looking at APM data that's being reported, make sure you're cluing in on the denominator, right? And what's in that. There's out of total medical expenditures, there's a percentage of those that are flowing through APMs. That denominator in some of the reports that they produce for us is out of the primary care spending. So, right, out of the proportion of total medical expenditures, there's going to be a portion of primary care. Out of that, then what is being able to be spent through APM. So there are a couple of different ways we track it, just something to note. I know there are a lot of people who like data that are on this call, but just flagging that as something to pay attention to as you're looking at different reporting of those numbers. All right, if you want to go ahead and hit the next slide. So one of the key activities of the Primary Care Payment Reform Collaborative, PCPRC for short, is to produce an annual recommendations report. So each year this group puts forward a set of recommendations for strengthening investment and supporting primary care. These reports are intended for a large stakeholder audience, so the division posts them on our website as the convener of this group. They are meant very specifically for the Commissioner of Insurance, right? Part of their role is to be advising us in the development of affordability standards, but they are embraced by other state leaders. HCPF is part of this table and is certainly part of making these recommendations and in ensuring program alignment when possible with the report recommendations. They are also intended for legislators. So we're going to have a great example of a legislator who was able to look at one of the recommendations and really build a bill that would help us in advancing this work. Other states, Colorado is about one of 12 states that are really looking at and measuring investment in primary care. So we know other states are also very interested in our work. So we've had 3 reports to date. If you want to go ahead and go to the next slide. In the interest of time, I am not going to go over all of the recommendations in detail. This gives you an idea. They are available on the website, the Primary Care Payment Reform website, which is on the previous slide. Year 1 is really looking at kind of some of the fundamentals, right? When we're talking about increasing investment in primary care, how are we constituting primary care, right? What kind of providers, what kind of services, how are we defining the universe of primary care in a way that makes it measurable? Also, initial recommendation around an investment target for primary care. Kind of 2020 was really doing a deeper dive around APMs, recognizing the importance of multi-payer alignment. Also, equity has been a strong theme throughout the work. I would say, 2020, Maria, a year like no others, the Anna's word list to borrow from the Queen, right? Really wanting to foreground and start looking at equity intentionally, which you also see carrying into this year. Really looking at health equity and APMs and making sure these are built in a way that is very much intentionally looking at decreasing health disparities and is not having unintentional impacts on safety net providers or other underserved populations. So if you want to hit the next slide. This talks a little bit about the report. Again, Maria did a great job of talking about the various components. For data nerds, you can go back and look actually at numerators and denominators and some of the definitions around that. If you want to go ahead and hit the next slide, I want to make sure that I'm giving enough time. Really, one of the key things that the division has done coming out of the primary care recommendations is institute investment target in primary care in the state of Colorado, to actually take that step to have a target in place in the commercial market. That puts Colorado in a group of about 5. And so what we did through this regulation, which was promulgated early in 2021, was to create a 1 percentage point investment target. So of a carrier's total medical expenditures, they need to be increasing the portion of that amount, which is allocated to primary care by 1 percentage point in 2022 and 2023. This is an initial target that is now in regulation. We know that this is an area that's underfunded, but the collaborative in making this recommendation and the division in implementing it wanted to be able to start looking at and seeing what that 1% increase, the impact that was having, and how that might inform future targets. Within this regulation, the division had also considered moving forward with a target for APM expenditures in the commercial market, but the commissioner very intentionally kind of put a pause on that. What you see in the regulation is kind of a target, and we ask carriers to report around it. But we really wanted to talk about multi-payer alignment and make sure what we were doing in the commercial market aligned with what was happening elsewhere. And with that, Representative Kennedy, I'm going to go ahead and skip the rest of my deck and kick it over to you, because I think that is where we picked up on a conversation earlier this year.
All right. Well, thank you, Tara, and thank you all for being part of this today. I'm just double checking to make sure that I don't have myself muted or anything dumb like that. Okay, I think we're good. So I want to go back a little bit. I've been having these conversations with a number of my colleagues that serve on the health committee with me for several years about how can we have the biggest impact, and there are a lot of ideas. We do some flashy things like the public option, but I see a lot of these things as being very limited or impacting kind of a narrow percentage of the market. And I don't have a ton of time to read journal articles, but I did invest in this particular area. So a couple of years ago, I started reading everything I could find in Milbank or Health Affairs about APMs, particularly in primary care. And then, I wasn't the sponsor on the 2019 bill, but I did help with it a little bit and have been pretty interested in following those annual reports. And so as I think about what are the biggest things we can do to make our healthcare system work better, two things have consistently come to mind, and none of these are new, right? These are things people have been talking about for a long time. One, invest in preventive care rather than sending people to the emergency room. And two, paying for healthcare differently, paying for value instead of volume. So I had kind of been seeking out where can the legislature pass a bill that adds value to the work that's already being done. And this idea around multi-payer alignment that was contained in one of the collaborative's recommendations really jumped out at me as something that I thought could have a powerful impact. And so, there were a lot of things already happening. The DOI had promulgated rules establishing these targets. And then, what I was noticing too is a lot of health insurance carriers were starting to take up APMs, but in a lot of ways they were doing it their own way. And I think that, there's an understandable tension between, innovation and letting these companies kind of get out there and figure out new ways to do things versus alignment, which streamlines things on the provider end. And I think that, understandably, the health insurance carriers had a greater focus on that innovation with a little bit less interest in the alignment piece. And so that was part of what we were hoping to accomplish with this bill this year, is kind of take that step forward on pushing greater alignment between all these things that are part of payment models, because by doing that, you can increase the uptake of APMs among the providers. I think the second thing that we were running into is there's a healthy skepticism of APMs out there because a lot of times it's brought up in the context of saving money. Now, saving money on healthcare is a huge part of what a lot of us have been talking about at the state capitol for several years, but there's a really important distinction to be made. We shouldn't be saving money by reducing our spending on primary care. Primary care, if anything, we should be spending more money on to bring down costs elsewhere in the system. And so we wanted to make sure that, there were questions about how the DOI might implement things through rulemaking. Now, I have a lot of confidence in how that would go based on the people I know who are over at the division and do this work every day. But, not everyone knows them as well as I do. And there were questions about what was going to happen. And so making sure we established in statute that this was not about crunching the primary care dollars into a smaller pot. It was really about increasing the value of our outcomes. And then connected to that same goal was this emphasis on equity. I think, this came up in a budget conversation earlier this year, but in maternity care, there has been concern that by switching to APMs, there's a risk of reducing access or putting further downward pressure on a system where providers may already be under reimbursed or where there may be very, very inequitable outcomes. And so we thought, and when I say we, most of the time I'm referring to myself and Yadira Carveo, who is my co-prime sponsor on this, that by codifying some language around the importance of equity and reducing health disparities, that we were going to be guaranteeing for the future that the progress we make on APMs would not come at the cost of the patients who have historically faced discrimination or really struggled in this system. And so that's where all of this started. Let's go forward one slide, please. So early on, it was based on these recommendations of the primary care collaborative that we started taking some inspiration. So I called Tara and we started brainstorming about how a bill could add value to the work that was already being done by the collaborative. At the same time, there were a couple other things that were happening, one of which was that the Division of Insurance had put in a budget request through the JVC, through the regular budget process, to provide funding for in additional collaborative work. The collaborative was doing its work, the state transformation collaboratives are kind of starting to get off the ground, and then we had this Baylit project that was mentioned in other slides before. But we also wanted to figure out a way to bring everyone together to the table to make sure this doesn't just end up being another report that ends up sitting on people's desks. We wanted this to get translated into action. So the Division of Insurance put in this budget request, which was approved ultimately, but we weren't sure whether that would be the case when we first introduced the bill, that funded more collaborative work, bringing in these stakeholders, bringing in the payers and providers and everyone else you can imagine in this space to dig in and start turning what had been a lot of studies into what would ultimately become really meaningful action. So that budget request established the process more than anything. And then we put in this bill some language that made very clear that we are intending for this to not just be within the commercial insurance market. We are hoping that this, brings in Medicaid, potentially brings in Medicare, depending on how some of the collaborative work goes, and learn from the best practices of all of the above. We certainly don't want to find the lowest common denominator here. Since everyone else has used the word denominator in their presentations, I had to drop it in here somewhere. But we don't want it to be the lowest common denominator. We wanted everyone to learn from the best practices and raise the bar. And so by establishing this process where everyone was involved and making clear that the goals are increasing primary care investment, improving health system outcomes, increasing access, reducing health disparities, and certain other elements that we know contribute to better care, like integration of behavioral health care, that we were going to really drive this in the right direction. Next slide, please. So in many ways, what the bill did was not exactly earth-shattering. It in some ways it was a clarification or a reinforcement of existing language, or just making very clear that these are what the goals we wanted to be in place. Because in some ways there were arguments that the Division of Insurance already had rulemaking authority to establish some of these things. But for us to make it very clear in this bill and for us to make the goals very clear, I think we're able to guarantee that the programs will be designed in a way that achieve the outcomes we're all hoping for. So really the crux of the bill was giving the Division of Insurance explicit authority to establish parameters that need to be aligned across APMs. And these included a certain set of quality metrics, so that we're not saying, insurance company A is making provider A use these quality measures, but insurance company B is making provider A use this different set of quality measures. It makes no sense for a doctor to have to log into their insurance portal to find out which quality measures are going to determine their payments. And so that establishment of aligned quality metrics was maybe the most important part of what we were trying to establish in the bill. And these other elements about risk adjustment methods, if risk adjustment is done wrong, that is the kind of thing that can incentivize doctors to drop their most expensive patients. We want to make sure we're actually incentivizing them to take on the more expensive patients that have maybe been historically underserved. the attribution methodologies. This is more of an administrative thing than anything, but if we make sure that all the insurance companies are attributing patients to practices in the same way, it's going to dramatically improve simplicity for providers in the space, and also the core competencies of what your practice is expected to do to be able to participate in an APM will help with that simplicity. And so the DOI will be promulgating these rules after they complete all of this stakeholder process that has been funded through the budget request. And then starting January 1, 2025, the insurance carriers are going to have to make sure their APMs are aligned. And it is our hope that by doing these steps that we're going to make it that much easier for providers, provide assurances that this is a smart move, that this is going to improve outcomes for their patients, and make sure that they continue to be paid and hopefully get paid more for the work that they do. And we're excited to see where this goes in the years ahead. So I'm grateful to all the folks on the call. You know, Tara and David and others were collaborators from very early on in the process, and I'm grateful for your help in turning this bill into a law. And with that, I'll turn it over to Trevor Abeyta at Healthcare Policy and Financing.
One of us had to talk on mute, and it was me, like on the webinar. And we have 4 minutes left, so I am going to truncate my presentation beyond belief. So we really at Medicaid agree with what has been said on this presentation. And with our APM strategy, we're valuing patients and providers over cost savings. And we believe that the only way you can generate cost savings is by improving quality and closing health disparities. And so our APM strategy is built around that. Next slide, please. So we have a lot of Medicaid at Medicaid. We have a lot of APMs in use at Medicaid right now. And we begun our APM journey with the APM1 program in 2018, and that's a pay for performance program, which is a category 2 APM, which Dr. Keller talked about. And in that program, primary care providers can earn enhanced reimbursement for meeting quality goals. So we continued down our payment reform journey with the APM2 model for non-FQHC and FQHC federally qualified health centers, since in Medicaid we speak in acronyms, and I realize not everyone knows our acronyms, provider types. And those programs begun in 2022. And what APM2 does, which is different from APM1, is that primary care providers can earn prospective payment rather than fee-for-service payment. So it is shifting more towards that category 4 payment model that Dr. Keller talked about, but there's still an element of a category 3 in there, which Dr. Keller alluded to. You set this up for me really well, Dr. Keller. And there are retrospective chronic condition episodes of care. So they're calculated after the fact, and we share those savings. I did laugh when Dr. Keller, I've said his name 10 times, talked about pediatrics. But we should have planned this because they're like overlapping presentations really well. And we heard loud and clear that pediatric patients are different than adults. The kids are not just little adults, right? And so the method of APM to use is going to be different. And so we are working, getting rolling with a collaborative design group to begin designing a pediatric track to the APM2 payment model, which will begin in 2023. And we believe in bringing the benefit of value-based payments to all Medicaid members. And so we are planning to, by 2025, cover all Medicaid members through the APM2 payment model. Next slide, please. I think we have 1 minute. Let's go to the next slide. So I do want to hit on, in my last minute, something that's very important to us in Medicaid, and that is using our APMs to close health disparities. And what we are doing in the APM2 payment model is we are stratifying quality measure performance by race and ethnicity to identify where there are health disparities. And what we're planning on doing as our payment reform programs continue evolving is sharing data with primary care providers on where there is disparities and then creating financial incentives to tie improvement in closing those health disparities to payment. And with that, I think we are at time, and I'm going to skip the rest of my slides. But thank you for having me, and it's been an honor to be on this panel.
Thank you guys so much. And I apologize that we ran to up to time and that we had the chat issues and all the things, but we did receive quite a few email questions. So we will be following up with those of you who did send an email. And again, if you have questions, sprigg, SPRIGG @civic.org is the best way to ask those questions. All of these slides are going to be recorded and available, so you'll have it, and you can always follow up with us at any point in time. Thank you so much to all the panelists for being here today and all the participants. We really appreciate your time and discussion, and I think this is great work that's happening in Colorado, really being looked at as a model for the nation for a lot of other states. So again, thank you, and sorry about the technical difficulties. It wouldn't be a good webinar without one, right? So enjoy, have a great rest of your day, everybody. Thanks so much.